Hi everyone. Now today we are going to check on cardiovascular nursing. As you know that cardiovascular nursing, of course, the same cardiovascular condition, maybe disorder, which are studied in nursing, they are the same one studied in clinical medicine or surgery. But now the depth of the knowledge is what vary from one cadre to another. So in this chapter, we are going to check on cardiovascular nursing, and on that, we are just going to segment our studies on congestive cardiac failure, or what you can as well call heart failure. I know the name congestive cardiac failure is not the first time you're hearing it, or heart failure. Okay, so the heart has failed, just lay from lay's perspective. Cardiac, just the other name of the heart. Okay, so we are going to check on the following under congestive cardiac failure. Remember, on cardiovascular nursing, it's more than just congestive cardiac failure. We have many other conditions. We have things to do with the rheumatic heart diseases, the valvular heart diseases, ischemic heart diseases. We have all that one. But here today we are going to check only on congestive cardiac failure. On that, we're going to check on the definition, etiology, those are the causes. We shall check on the precipitating factors and heart failure, or the factor that precipitate heart failure mean. We shall check on anemia, infection, thyrotoxicosis, dysarrhythmiasis, classification of the heart failure as well. We check on the systolic failure, diastolic failure, mixed systolic and diastolic failure. Shall check on the pathophysiology of heart failure, how it occurs, how it happens, okay? And the compensatory mechanism, be it sympathetic nervous system activation or neurohormonal response or dilation or hypertrophy. And then types of heart failure, we are going to check on the left-sided failure, right-sided failure. Then on clinical manifestation, which we shall as well check on how somebody with congestive cardiac failure manifests. We shall check on complication of heart failure and the management of heart failure. That is the goals of the treatment as well, and the pharmacological, in a way that which drugs are used in heart failure. So that is that. I'm pretty much sure that you guys can still recall your primary knowledge. That is from class 7. You did study something called circulatory system. On the circulatory system, you did study heart. Realize that heart is one of the organ, actually it's located in the thorax, on the very left side of the thorax, the left lower side of the thorax. Okay, so you remember thorax is one of the cavities. Then we have the ventral cavity and the dorsal cavity of the body. So the ventral, we have the thorax, the abdominal, and the pelvic cavity. And then the dorsal, the one which are found the back, we have the vertebral column cavity and the spinal cavity, or the cranial cavity, just the brain. So in the thorax, we have lungs and we have heart. They are both two cavities. So in thorax, we have pleural cavity, which has the lung, and then we have pericardial cavity, which has the heart. So in Form 2, when you are doing biology, you study circulatory system as well. And you did analyze on the component of circulatory system. You talk about the heart itself, the blood vessels, and then the blood. So you realize that the heart is just like a pumping machine. So it takes in blood from the part of the body and pump it back to the part of the body. But first, it has to take it to the lungs for oxygenation before pumping it again to maintain the circle. And you realize that we had double circulation in human beings. So that is the systemic circulation, the systemic circulation and pulmonary circulation, unlike in the insect and arthropod, which has got only one circulation, what we call a single circulation. So this heart, it has got a muscle, and that muscle is what we call the cardiac. So it has to be supplied with the blood. So anything that will interfere with its function, its normal function, will result for it to fail. So even at the time we're going to check on the causes, you realize that the causes are just other diseases that can as well attribute to the failing of the heart. So on the progress, now let's start. First thing I'll start is with definition. We are going to define what is congestive heart failure. And this is just an abnormal clinical syndrome involving impaired cardiac pumping or failing. So congestive cardiac failure is associated with many types of cardiovascular diseases. So it has no root origin as a primary event, or maybe a condition that starts automatically from nowhere. It is linked to things to do with hypertension, that is increase in the blood pressure. Remember, normal blood pressure is supposed to be at a systolic measure of 120 over diastolic of 80 millimeter of mercury. It can as well be associated with conditions such as coronary artery diseases and myocardial infections. So things to do with the bacterial infection of the heart, like endocarditis, inflammation due to bacterial infections. Okay, so all those can attribute to congestive cardiac failure. So when you talk about etiology, we have several things that can attribute to etiology of the congestive cardiac failure. There are very, very many, starting from coronary artery diseases, advancing age, hypertension, diabetes mellitus, cigarette smoking, obesity, high serum, rheumatic heart disease, hyperthyroidism, valvular disorders, and myocarditis. So we'll be checking each of them. Now, first of all, remember coronary heart diseases. Coronary heart diseases, you study them in Form 2. And as I can also remember, that the heart is supplied with blood vessel, which were called the coronary artery and coronary vein. The coronary artery was supplying oxygen, the oxygenated blood and the nutrited blood. So it will supplying nutrient and oxygen to the heart so that it can keep pumping. Remember, with oxygen, we get the contraction. The mitochondria can now produce energy, the ATP molecule, adenosine triphosphate. Now, the coronary vein was doing the work of taking the metabolic or the byproduct of that metabolism of the cardiac muscles. So it takes all carbon dioxide from the combustion, it takes all the nutrients, which are now the metabolites, and it relieves it. So this circulation enriches and it nourishes the heart. So failure to this, when you have any condition on the artery or the coronary artery, it will significantly bring in things to do with myocardial infarction, like acute myocardial infarction, can bring in things to do with angina, can be unstable angina, and many other things. Okay. So eventually we can have congestive cardiac failure. Another cause is advancing age. We tend to realize that most people who are aged, they normally have heart diseases. This is because of tear and wear, degenerative condition. The blood vessels become lignified, strengthened with a lot of things. And therefore, even the tunica media and internal media of the blood vessel, the smooth muscle, the fibro muscle become rigid in a way that the pliers, the compliers, or the flexibility of it, dilation, constriction does not work okay. So the heart tend to receive resistance from the peripheral circulation. And in that essence, you get to realize that the heart will fail. So we'll have congestive heart failure. So with age related, it's just something to do with the normal aspect. But of course, we know very well that cardiac failure can be a long-term thing. It doesn't happen once. So with as you age, lifestyle also attribute to this. So people who live healthy lifestyle, when they're young, their aging life is not complicated with primary diseases like congestive cardiac failure. Talk about hypertension. Hypertension is increase in systolic blood pressure above 120 and diastolic above 80 millimeter of mercury. At most, for us to diagnose in the clinical setup hypertension, first we need to actually recognize some clinical presentation, such as morning lightheadedness and occipital headache. We can have blurry vision or maybe somehow impaired vision. Okay, and fatigue sometimes. So blood pressure, hypertension comes with a lot of symptoms. Apart from that one, we need to have 3 random tests done in 3 random days, and the hallmark is the mean of this. I mean, blood pressure measurements should be at least 140 over 80 millimeter of mercury. That is 140 systolic pressure and 1 over 90. I mean, diastolic pressure. So that is that. So with hypertension, with increase in pressure, that is, the heart will overly pump, and there might be issues with the valves, and then entirely we'll get to have congestive cardiac failure. Diabetes is another cause of congestive cardiac failure, but with diabetes, remember we have diabetes type 1 and 2. Each of them comes with different clinical presentation, and each of them always have different management guide. So, but they have one complication where they tend to have the neuropathy, retinopathy, and nephropathy. So the nephropathy interfere with the kidney, and renals are connected to the blood circulation because they filter the blood. So if they do not filter the blood because they are either impaired, what we'll have is increased volume of blood volume, increased blood volume in the body. Therefore, the heart will have very hard time pumping, thus increasing blood pressure. That is hypertension comes in, and then the congestive cardiac failure plays in. So anything that plays with the renal, kidney, we get that. Cigarette smoking as well can bring in congestive cardiac failure because of the compounds in the cigarette itself and many other health related problems that cigarette can bring to you in the lungs, which can interfere or be subsidized as like copulmonale. Therefore, we'll get to have issues with the cardiac. So obesity and high serum cholesterol also can play a role, because with obesity and high serum cholesterol, because it's low low lipodensity lipids. I mean, these ones, the cholesterol, they are unsafe or bad lipids. Okay, so they will cause plaques of fat streak on your vessel, restricting blood, increasing the peripheral resistance, therefore raising the blood pressure. Therefore, as for that, we'll get congestive cardiac failure. Obesity as well, when you have a lot of fat, such will still happen. The lipid will come in, they clog the blood vessels, difficult in pumping mechanism, the heart will fail. Rheumatic heart diseases. This is because of maybe rheumatic fever, which normally is due to autoimmune reaction of untreated, what we call the, hemolytic streptococcus, hemolytic beta B, streptococcus sort of, the ones which are responsible for rheumatic fever. So these kind of bacteria, they will interfere with the joints, and also they will interfere with cardiac muscles, the valves, okay, the coronary, the tendon coronary, and so on and so forth, and then they'll bring in cardiac failures. Hypothyroidism comes with the increased metabolism and many other deteriorated part of the body. Yeah, it comes with hypertension, comes with many other things that can as well connect to the congestive cardiac failure. Valvular disorders like mitral stenosis, both we have mitral regurgitation, mitral stenosis. We can now even have mixed valvular disorders. So those ones are also key things that you should also check. Myocarditis, inflammation, inflammation of the cardiac muscles, okay, due to maybe bacterial infection, something. So that one can as well bring in congestive cardiac failure. So that is that. So precipitating factor is anemia. Assume somebody is having anemia to mean that there is maybe few HBs, that is hemoglobin, or the blood cells, the red blood cells are less. So there will be reduced oxygen carrying capacity of the blood, which will stimulate increase in cardiac output to meet tissue demands. So with that, increased demand of tissue, increased cardiac output, so the heart will tend to beat too much, and therefore we'll have congestive cardiac failure. Infection causes increased oxygen demand of tissues, thereby stimulating increased cardiac output. Thyrotoxicosis changes the tissue metabolic rate, increases the heart rate and workload of the heart. Things to do with dysarrhythmiasis. It causes decreased cardiac output because now when the heart rhythm is not as usual in the ECG, the PQRS complex, so that decreased cardiac output and increased workload due to oxygen requirement of myocardial tissue will result to cardiac failure. So interference with the normal mechanism which regulates the cardiac output may cause heart failure, whether you like it or not. So cardiac output depends on the preload, afterload, things to do with the preload. I know you know them. Afterload, okay, and myocardial contractility and the heart rate as well. And the preload is just the volume of blood in the ventricles at a distal before the next contraction. Before the next contraction, you have preload. Okay, so the preload determines the amount of stretch placed on myocardial fiber, and then afterload is the peripheral resistance against which the left ventricle must pump. So afterload is affected by the size of the ventricle, wall tension, and arterial blood pressure as well. So cardiac output is amount of the blood pumped by each ventricle in 1 minute, and it is always calculated by multiplying the amount of blood ejected from the ventricle with each heartbeat. So the stroke volume, we multiply the stroke volume by the heart rate, and then we'll get the cardiac output, because the stroke volume is the amount of blood ejected from the ventricle with each heartbeat. So cardiac output is always the stroke volume times the heart rate, and then you get it. So classification of the heart failure, classification of heart failure, the way I've just told you. Okay, classification of heart failure, we have systolic failure, diastolic failure, mixed systolic and diastolic failure. So systolic failure, the result from an inability of the heart to pump blood effectively. It is caused by either impaired contractile function like myocardial infarction, okay, valvular heart disease, the heart valves are dead, maybe they have issues, hypertension, okay, and the left ventricle is systolic dysfunction, loses its ability to generate enough pressure to inject the blood forward through the heart, and therefore we'll have the systolic failure. As much as the heart cannot pump, we call that systolic failure. Diastolic failure is the inability of the ventricle to relate and fail during diastole. The ventricle now cannot fail. And then we have mixed systolic and diastolic failure, to mean that the heart cannot pump, and then it can also refill cannot also refill itself. So systolic and diastolic failure is of mixed origin and is seen in diseases states such as dilated cardiomyopathy. Dilated cardiomyopathy, is a condition in which poor systolic function is further compromised by dilated left ventricular walls that are unable to relax. So, pathophysiology of the heart failure, how does it occur? Normally, you can give it basically based on the etiology of what causes the heart failure. But the generalized approach is the heart failure will always result from the inability of the heart to pump blood effectively. So, be it the left ventricle, which loses its ability to generate enough pressure to inject the blood forward through the aorta. And over time, the left ventricle becomes dilated, hypertrophied, that is increases in size, and this leads to decrease in the left ventricular ejection fraction. So the right and the left ventricles have the inability to relax and fill during diastole, and this decreased filling of the ventricle results in decreased stroke volume and cardiac output. So normally when this happens, we'll have compensatory mechanisms. So the heart will tend to compensate for what is happening, compensatory mechanism, and that is what we are going to talk about: sympathetic nervous system activation, neurohormonal responses, dilation, and hypertrophy. So, so in the heart failure, the overloaded heart will now resort to compensatory mechanism. It will try to maintain adequate cardiac output, and the main compensatory mechanism include things to do with sympathetic nervous system activation and neurohormonal responses. And they love dilation and hypertrophy. So things to do with sympathetic nervous system activation. So in response to an inadequate stroke volume and cardiac output, there is increased sympathetic nervous system activation, resulting in the increased release of things to do with the catecholamines. If you can remember catecholamine in endocrinology, things to do with epinephrine and norepinephrine. Okay, so this will result in increased heart rate and increased myocardial contractility and peripheral vasoconstriction as well. Then you have that is sympathetic nervous system activation. Then you have neurohormonal response. So the cardiac output falls, blood will now flow to the kidney, will start to decrease the flow to the kidney because the cardiac output is now falling. And this is sensed by what we call the juxtaglomerular apparatus. I know you study them in kidney, in anatomy and physiology. Juxtaglomerular apparatus in the kidney has decreased volume because it will be sensed. The blood, if the blood pressure is reduced in the kidney, the juxtaglomerular apparatus in the kidney will decrease, will sense the decrease. So in that response, the kidneys will release what we call the renin, which converts anti-angiotensinogen to angiotensin 1. And then the angiotensin 1 is subsequently converted to angiotensin 2 by a converting enzyme made in the lungs. Okay. So angiotensin 2 now will cause the following. One, the adrenal cortex to release aldosterone, which results in sodium and water retention. Two, increased peripheral vasoconstriction, which increases blood pressure. And then three, this is now what we call the rush. Now that will now lower cardiac output, causing a decrease in cerebral perfusion pressure. And the posterior pituitary gland then secrete antidiuretic hormone, also called vasopressin, and this ADH, okay, it will increase water reabsorption in the renal tube, causing water retention, therefore increase the blood volume as well. So that is neurohormonal, both in the pituitary and in the adrenal cortex. Adrenal will only secrete aldosterone, but pituitary gland will secrete ADH as well. So that is that. Dilation. Dilation. How does dilation work? Dilation is the enlargement of the chambers of the heart. It occurs mostly when the pressure in the heart chambers is now elevated over time. So it has, like imekai, it has just been elevated ever. So the muscle fibers of the heart will stretch in response to the volume of the blood in the heart and at the end of the diastole. So the degree of the stretch is directly related to the force of the contraction system. And this increased contraction initially leads to increased cardiac output and maintenance of the arterial blood pressure and perfusion. So things to do with the dilation start as an adaptive mechanism to cope with the increased blood volume. But eventually this mechanism becomes inadequate because the elastic element of the muscle fibers are overstretched and can no longer contract effectively, thereby decreasing the cardiac output. Talk about hypertrophy. Hypertrophy is another thing. And now hypertrophy is just an increase in the muscle mass, and the cardiac wall will thicken in response to being overworked and strain. Okay, so this is a compensatory mechanism, but now the mass of the wall of the cardiac has increased in size. So it occurs slowly because it takes time for this increased muscle tissue to develop. But hypertrophy follows persistent chronic dilatation and thus further increase the contractile power of the muscle fiber. So this will lead to an increase in cardiac output and maintenance of tissue perfusion. So cardiac compensation occurs when compensatory mechanism succeeds in maintaining an adequate cardiac output that is needed for tissue perfusion. Cardiac decompensation. Cardiac decompensation. Remember that is cardiac compensation. I'm talking about the cardiac decompensation now will occur when this mechanism can no longer maintain adequate cardiac output and inadequate tissue perfusion results. So then we'll have heart failure. So let's talk about the two types of heart failure, the left-sided failure and right-sided failure. Okay, left-sided failure and right-sided failure. Now, left-sided failure, it results from left ventricular dysfunction. The left ventricular dysfunction prevents normal blood flow and causes blood to back up into the left atrium and into the pulmonary veins. So the increased pulmonary pressure causes fluid movement from the pulmonary capillary bed into the interstitium and then the alveolar, which manifests as pulmonary congestion and edema. So we'll have pulmonary congestion, we can have pulmonary edema, we can have pulmonary effusion. All those ones can come into being. Okay. Then right-sided failure. Right-sided failure causes a backup of blood into the right atrium and venous circulation. Okay. So the venous congestion in the systemic circulation results in jugular venous distension, hepatomegaly and splenomegaly in peripheral, you may realize. So right failure, what I want you to understand is left-sided failure, the left ventricular dysfunction. So there will be no normal blood flow, and it will cause blood to back up into the left atrium and into the pulmonary vein. So what is the effect? It will manifest clinically with the lung conditions, be it pulmonary congestion, pulmonary edema, pulmonary all those ones which can come to be. But now right-sided failure, because the blood coming to the right side of the heart comes from the systemic circulation. And therefore, that means if it is failing, then the blood will go back to the systemic. So you'll get the venous, because vena cava is what brings blood into the heart from the right side. So we'll get venous congestion in the systemic circulation, and that will result to symptoms such as jugular venous distension, okay, hepatomegaly, that is swelling of the liver, splenomegaly, and peripheral edema, like there will be swelling of the peripheral part of the body. So clinical manifestation of a client with CCF, realize that this client first is fatigue, sometimes caused by decreased cardiac output. So there'll be impaired perfusion of vital organs, decreased oxygenation of the tissue, and anemia. And if anemia can come, then it can result from poor nutrition, renal disease, or drug therapy. Thing to do with angiotensin converting enzyme inhibitor like ACE can result cause anemia as well. Dyspnea is a shortness of breath. It's also one of the clinical manifestations, and it is caused by increased pulmonary pressure due to interstitial and alveolar edema. So dyspnea can occur with mind exhaustion or at rest, and orthopnea is shortness of breath as well. So that can occur when the patient is in a recumbent position. Recumbent position or lying flat, or what we call lying supinated. Paroxysmal nocturnal dyspnea is shortness of breath that occurs when the patient is asleep. We call it paroxysmal nocturnal dyspnea. It is caused by the reabsorption of fluid from the dependent body areas when the patient is in recumbent. So the patient awakens in panic and has a feeling of suffocation and a strong desire to seek relief by sitting up. So mostly realize that this patient develop adaptive behavior such as sleeping with two or more pillows to aid their breathing. Tachycardia is one of the clinical presentation as well. And the tachycardia is just increase in heart rate and because of diminished cardiac output. So there is an increase in pathetic nervous system stimulation, which increases the heart rate. Edema. Edema is the accumulation of fluid in the tissue, vasculature, or maybe tissue compartments. So it may occur in dependent body areas such as peripheral edema. It can occur in the liver, and then you'll have large liver like hepatomegaly, abdominal cavity, and then we'll have ascites, and lungs, which will have pulmonary edema and pleural effusion. So if the patient is in the bed, sacral and scrotal edema may develop. And this is now the patient who is at the bed. So pressing the edemaceous, or what we call the edematous skin with the finger, may leave a transit indentation. That's what we call pitting edema. We can have non-pitting and pitting edema. That one we'll see on the other day. So nocturia. Nocturia, heart failure with decreased cardiac output causes impaired renal function. or perfusion, and that decreases urinary output during the day. So, however, when the patient lies down at night, the fluid movement from the interstitial space back into the circulatory system is enhanced. So, this causes increased renal blood flow and diuresis, and the patient may complain of having to void 6 to 7 times during the night. Skin changes can also take place, so the skin of the people with heart failure may appear dusky. This is because the tissue capillary oxygen extraction is increased, and the skin may also be cool and damp to touch. So the lower extremity are shiny and swollen with diminished absence of hair growth at those regions. Behavioral changes due to cerebral circulation may be impaired with chronic heart failure due to decreased cardiac output and poor gas exchanges. Chest pain occurs in heart failure due to decreased coronary perfusion from decreased cardiac output and increased myocardial work. Weight changes. Weight gain is also caused by fluid retention. Okay, so abdominal fullness from ascites, hepatomegaly causes anorexia and nausea. So you can either lose weight. So let's talk about complications of heart failure. Things to do with the pleural effusion, dysarrhythmias, we talk about them, left ventricular thrombus, hepatomegaly, renal failure. There are very many. And then we shall check on the management of heart failure, the nursing management, okay? The nursing management. So that is that. So meanwhile, I think for the day, that the short. So after this, you'll get the exams of today.